Hello, and welcome to session 14 of our COVID-19 webinar series. I am Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy. For those of you who are not familiar with the Alliance, we are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. The Alliance launched this series to provide insight into the status of the COVID-19 response, as well as shed light on remaining gaps in the system that must be addressed to limit the severity of the pandemic's impact in the United States. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting this series. You can join today's conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We want you to be active participants in today's discussion, so please get your questions ready. Here's how you can ask them. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time. We will collect these and address them during the broadcast. You can also use that icon to notify us about any technical issues you may be experiencing. Background materials, including the slides, are available on our website, allhealthpolicy.org. A recording of today's webinar will be available there soon. As a number of states begin to lift stay-at-home orders, questions remain around strategies to curb the continued spread of COVID-19. Public health officials are ramping up efforts to monitor and contain new cases through contact tracing, a disease control method used to identify and notify individuals who may have been exposed to the virus. The strategy is a key component of other nations' efforts to safely ease social distancing measures. During this webinar, panelists will discuss case studies from abroad and best practices as policymakers look to implement a contact tracing strategy in the United States. And now I'm pleased to introduce the Alliance's board chair, Dr. Reed Tuckson, to introduce our panelists and moderate today's briefing. Thank you for being with us today, Dr. Tuckson.
Well, thank you very much, and we thank all of you for listening in on a very important and obviously timely conversation, lessons from home and abroad, implementing a contact tracing strategy. What we hope you'll get out of this is that you will learn the importance of contact tracing at this stage in the pandemic, that you will have a chance to examine case studies from other countries as we learn from their tracing and surveillance efforts. We want to identify successful contact tracing strategies and highlight the infrastructure that is necessary to support this critical activity. And finally, we want to explore the role of the private sector, non-government organizations, and community organizations in doing this, and distinguish between what the federal response ought to be and state and government response and how these work together. Well, we have a great panel to discuss this with us, and to start us out, each of our panelists will have 5 to 7 minutes where they will make comments, and then we'll introduce the next one and then the third speaker, and then we will have a bit of a moderated question and answer period, and then we will turn it to you in our last half hour for your questions and your input. To begin, I'm very pleased that Anand Parekh has joined us. He is the Chief Medical Officer of the Bipartisan Policy Center, and for a decade, he was the HHS Deputy Assistant Secretary for Health, clearly a person of great experience in doing important work now. He will discuss the findings from a recent BPC report comparing countries' approaches to ease social distancing measures and how those lessons might be applied to the United States. Anand, thank you so much.
Reed, thanks so much for that introduction. It's great to be with all of you today, and thank you again to the Alliance for the invitation. As Reed mentioned, I'll just be summarizing some of the lessons learned from a Bipartisan Policy Center report. I think you have that in your material set. The context here is, though we're still in the midst of the first wave of the pandemic in the United States, as we know and hear, elected officials are poised to open up the economy. I think most states are in the process or have stated their intentions to start this process in the coming days and the weeks. And so the premise of our recent work was, as a nation with 50 states here, let's not make policy in a vacuum. Let's realize that there are dozens of countries around the world that are temporally ahead of us, or at least in sync, all sort of looking at this and trying to figure out how do you ease social distancing or physical distancing interventions, and the question is, what can we learn from them? Realizing that every country is different: size, government, our notion of federalism, culture, the extent of personal freedoms. There is no one-size-fits-all pandemic plan, but there are lessons, and what are those lessons? So our methodology was, we looked at 15 countries, 10 European countries, Austria, the Czech Republic, Denmark, France, Germany, Italy, Netherlands, Spain, Switzerland, and the UK. And we looked at 5 East Asian countries, so South Korea, Taiwan, China, Singapore, and Hong Kong. And the qualitative information we collected, we got from what's called the Health Systems Response Monitor. That's a collaboration between the WHO and the European Commission and the European Observatory. We spoke with experts from the Commonwealth Fund's International Health Policy and Practice Innovations Program. And we also read through published literature as well as media reports. And I want to just spend a couple of minutes summarizing the overarching findings of our recent report, and then maybe spend an extra minute or so on contact tracing. So very quickly, I think the overarching findings when it comes to loosening social distancing interventions, number one, there really weren't too many countries that had explicit, transparent, quantitative criteria vis-a-vis loosening social distancing interventions. I think some countries are looking at the transmissibility factor, are not. Others are looking at cases. Of course, that's limited via testing, but not too many countries had sort of explicit criteria, gating criteria, if you will. In terms of sequencing of sectors, most countries, of course, are looking at the risk of transmission. So sectors that are low risk of transmission opening up first. Some countries are actually also taking into account the importance of the economy as well, and trying to figure out what's that sweet spot, low risk of transmission plus importance of economy. In terms of time frame between phases, most countries looking at 2 to 3 weeks to assess the impact of infection spread prior to opening up other sectors of their economy. In terms of school openings, no real consensus across these countries. Some countries looking at opening up schools early, some late. Some of this differs based on the level of schooling, primary, secondary, or higher ed. I think one opportunity here for the US is to track particularly East Asian countries, since their school year is year-round, and so that might provide some insights for us in the fall. In terms of testing, we looked at how many tests are being done in these countries and who is being tested. We looked at specific regions that have been successful, like Venetia in Italy, as well as looked at countries that had explicit stated goals. And if you extrapolate that to the United States, sort of the number or range we came up with is about 4 to 5 million tests per week to really be in a good position to loosen social distancing interventions. In comparison, here in the United States over the last 7 days, we're just under about 2 million. But it's not just how many you test, it's who you test. And so many of these countries focusing now on vulnerable populations who are asymptomatic, whether it's frontline workers, underserved groups, minority populations. In terms of isolation, many countries looking at temporary housing for those who are infected who can't recover at home to really break those household transmission chains. In terms of masks, really most countries we looked at are mandating cloth-based masks in areas where social distancing is not possible, like public transport and grocery stores. And then in terms of communication, while loosening, countries are being sure, I think Switzerland provides a good example of being sure to emphasize the continued importance of hand hygiene, respiratory etiquette, physical distancing, and cloth-based masks, sort of the new normal. And then finally, sort of a minute or two on contact tracing and what we were able to glean based on this cross-country analysis. To the extent that countries provided definition of what they mean by contact tracing, essentially, at least in a couple of definitions we found, in relation to a confirmed case, we're really talking about individuals who are within 6 feet without a mask for 10 to 15 minutes, 2 days prior to a confirmed positive test, or 2 days prior to the start of symptoms in a confirmed case. In terms of the process, how this is done across countries, most countries are utilizing government employees, some using military, not as many countries using volunteers. Really, it was unclear how many have public health backgrounds, but most countries using teams of people at multiple levels, local, state, federal, having trainers, call centers, staff, again, checking in with these close contacts over a 14-day period. We didn't find a lot of specificity whether testing was required for these close contacts, nor did we find a lot of specificity across countries in terms of, for these individuals, are they being provided services over the 2-week period, housing or food, etc. In terms of quantitative metrics, the two countries that had quantitative metrics, one is China, particularly Wuhan, where they had 1,800 teams of 5 contact tracers, so essentially 1 for every 1,200 citizens, and in Germany, 5 contact tracers per 20,000 population. And that roughly relates to sort of what we're hearing here in the United States, sort of a broad range of, perhaps we need anywhere from 100,000 to 300,000 contact tracers, and the 300,000 is sort of more in the range of Wuhan. The 100,000 that we hear about here in the US is more in the range of Germany. And then the last point I'll just make is there's been quite a bit of attention, and I'm using that word very carefully and not saying emphasis, on digital contact tracing as a supplementary tool to manual contact tracing. Certainly in East Asian countries, we've seen for the monitoring and surveillance of infected individuals, governments mandating some of these tools. But I think Singapore is probably the best example with their Trace Together app for close contacts. Essentially what that app does is create a log of other smartphone Bluetooth signals within a 6-foot radius. Now an individual has to download the app, and then if they become, if they turn positive, then they have to report that into the app, and then that signals other potential individuals who were in close proximity that they may be infected. Of course, there are cons here. There's been sort of a low uptake rate in Singapore, about 12%, where experts think you need about 60%. There are also some false positives. That being said, many European countries, for example, Australia, are planning to utilize digital contact tracing. Of course, the key questions are, for example, where is the data being stored? Is it centralized? And if so, what are the privacy issues? Is it decentralized? In fact, many of US corporations like Apple and Google are sort of more focused on the decentralized pathway. So many questions there, but definite evidence that digital contact tracing, at least as a complementary or a supportive measure to physical manual contact tracing, is being used. So anyhow, that is just a high-level overview. Again, what we were trying to do is tease out across European and East Asian countries, what are the pearls, the lessons learned that we can use here in the United States as we relax these social distancing interventions, and a few comments on contact tracing. But looking forward to joining the discussion in a few minutes.
Thank you so much. Well stated, and a great lead off. That turns us now to Rudolf Blankart, Professor of Regulatory Affairs at the KPM Center for Public Management at the University of Bern. He's also Director of a Public-Private Partnership in the field of translational medicine. His research is at the interface of medicine, management, and law, and he will explain for us how Germany is leveraging public health workers for contact tracing and targeting resources into high-risk communities. Welcome, Rudolf.
Thank you, Reid, for this nice introduction. I've presented some slides, and I hope that the next slide will just show up. So I want to show the lessons learned from Germany. And the next slide, please. Therefore, I want to give you some insights or kind of contextual factors about Germany. So Germany is in the middle of Europe, and it's also a federalistic country, similar to the US. So we have 16 federal states that have quite a lot of power, similar to the United States. It's about as large as California with 137,000 square miles and 83 million people, so about double the size according to population. But we do not have these super cities like New York, Paris, or London. Berlin, the largest city, the capital, has about 3.4 million, and other cities which are larger than 1 million is Hamburg, Cologne, and Munich, and we will see Munich afterwards again. From the healthcare system, we have a compulsory healthcare system, health insurance, where everybody has to have an insurance. Across the country, there are almost 2,000 hospitals with 8 beds per 1,000 people. This is similar what the US had in 1970s. Nowadays, the US has about 3 beds per 1,000. However, you have to account that Germany is said to have a lot of beds, almost too many beds. If you look at the intensive care beds per 1,000, we are at 0.34, which is about the number of the US. However, we have increased the number of beds during the Corona crisis to about 0.5 beds per 1,000, with now about 40,000 beds in total. And regarding testing capacity for COVID-19, we are slightly below 1 million tests per week. Also, you have to say that not 1 million tests are actually performed. It's about 600,000 to 700,000 that are actually performed. And this was kind of an effort to increase that number of tests. So next slide, please. If you look how on the map of the different federal states in Germany, you see that the COVID-19 cases per capita are pretty heterogeneous. You see that the COVID-19 spread from south to north. There were 2 events. First of all, we see Italy, where the virus has spread quite a lot, and this pushed north to Bavaria and Baden-Württemberg. And then, on the other hand, from Austria, there were skiing areas where they have closed very late the skiing resorts, and many people, especially from Bavaria and from Hamburg, have been there in places like Ischgl, and they brought the virus to Germany and spread it there quite a lot. And this you can still see on the map of the COVID cases. If you look on the right top side, you see the new cases per day, and you see that about mid-March, the hard restrictions were in place. We never had a lockdown similar to Spain or to Italy, where nobody was allowed to go on the street. The people were allowed to go outside, but they were just allowed to meet about a maximum of 1 other person. And during the restrictive phase, the number of new cases per day has been reduced substantially. And mid-April, there was a start of loosening restrictions. As Anand told, there are no kind of fixed values that should be reached, as nobody knows these values yet. And so it was a kind of a step-by-step approach where every week some more restrictions were loosened. You also have to know that the restrictions are not set by the central government, as it's a federalistic country. Each of the 16 federal states has to do their own loosening efforts, and so it's slightly different between the federal states. Basic control metrics are the reproduction number, the doubling time, so how long does it take until the number of infected people doubles. That went down from about 2 days, 1 to 2 days, to more than 100 days times. And there is a threshold of 50 cases per 100,000 people per week, where and if one community, so Germany has about 300 communities, when in one of these communities the threshold is hit, then there will be lockdown measures in place again. But right now they are loosening. Only if you hit these 50 per 100,000 cases a week, then you have to lock down. Some of the states are even reducing this number to about 35 to 30 cases because they think that 50 is too much. And another thing is that antibody testing will come soon and will be an add-on to the measures right now in place. Next slide, please. Here is just an overview how the basic reproduction number evolved. The first restrictions, kind of lower restrictions, like forbidding events with more than 1,000 people, social distancing, calls for social distancing. They reduced already in the beginning of March the number of infections or of the number R. The basic reproduction number says basically, it says how many people does one infected person generate or how many new infections does one infected person generate. And as long as it's below 0, the number of infected people drops. And you can see there on the right side where the steps of loosening the restrictions, that it stayed below 1, which is fine. But during the last 4 days, it increased above 1, which is not a good sign, but there is a huge uncertainty. And the last 2, so it was 2 days above 1, and now it's below 1 again the last 2 days. Next slide, please. So I told, so what may be the benefit, or what has happened, or what are the regulations that have of major importance in Germany? First, it was the National Infection Protection Act that regulates the interaction between the federal, state, and the state governments. And it defines the role of the National Robert Koch Institute, the RKI. That's probably comparable to the US CDC. And this institute that gives recommendations to the federal states and to the central government how to act. And but the federal states governments, they are responsible to enact these ordinances and regulations to protect their citizens. And the second thing what Germany has done was that they prepared a national pandemic plan in 2005, shortly after the SARS crisis. In 2003, they drafted this plan and updated it in 2017. This was basically based on 1999 guidelines of the WHO, and this resulted in company and institution pandemic plans that all institutions such as orphanages, nursing homes, schools, they had to have a pandemic plan where it says, for example, that on 100 beds in a nursing home, you need 15 rooms to separate people. Or what Germany also had is a special telephone number to call for COVID cases that you had. This was the 116, 117. And compared to other countries where it was kind of the 911 number, these numbers were kind of overcrowded, which caused other problems of people who had kind of myocardial infarctions. They couldn't come through. So this was a very important thing as well. Next slide, please. I just wanted to give you one insight how contact tracing actually works here in the city of Munich. The city of Munich is a part of the federal state of Bavaria, and the city of Munich has probably the largest public health authority in Germany and is responsible for 1.4 million people. Basically, physicians, hospitals, and public health authorities may prescribe tests, which results are then reported to a state database, and this state database is going then to the Robert Koch Institute, to the national database that derives their things. But the public health authority is also informed about an infected individual shown in red, and they contact the red infected individual, and the infected individual has to report all their contacts, which they had over 15 minutes. And also this infected individual is put into quarantine at home or in a Corona hotel, which is a 4-star hotel, actually, or it has to go in hospital. Then the public health authority also contacts all contact persons 1, which the infected individual reported. The suspected infected people, they have to go to quarantine as well for 14 days, whether they have symptoms or not. Whether the test is negative or not, they have to go for 14 days. And they also, and if they have the suspected infected people are infected as well, then the whole circle starts again. So next slide, please. So just as you probably know, Germany came pretty good out of the crisis until now. We don't know what happens, but what are the success factors? What we see now is probably preparation. So they had a national pandemic plan and a good healthcare system. The Germany had also luck. It was not the first to be hit and had some experiences from other countries like Italy. They also had experiences in spotlights like BMW, who was hit by the skiing resort crisis, and Webasto. They have access to a healthcare system and testing, which is pretty good. So tests are free in Germany. So everybody actually who wants to have a test gets a test. There is excessive testing capacity, and the population is used to access the healthcare system. At last, there's a fast and comprehensive testing where special groups, they get their results within 2 hours, and general population 6 to 8 hours. The infection prevention is also done first, put first. So in they involve key people to have access to minorities, and they waive prosecution of kind of illegal immigrants, etc. And a large role is also playing that you go to the physician and that you go to quarantine is the social security system, which is important to have, that you have an unemployment assistance, and that you also have short time work, which is subsidized by the federal state. So you're not losing your job just because you are in quarantine. So that's my slide for now. And I hand over, I think I'm out of time, and I hand over to Reed.
Thank you so much, Rudolf. Appreciate it. And now for our third speaker, KJ Sung, who is Assistant Professor of Medicine at Brigham and Women's Hospital, but he's particularly important for us on this particular conversation because he's the project leader and observational study principal investigator for Partners in Health. Partners in Health has really been bolstering Massachusetts' contact tracing workforce and has the lessons learned on best practices that state and federal policymakers can utilize. KJ?
Thank you, Reed. Can you go to the next slide, please? I am part of the Massachusetts Community Tracing Collaborative, and I want to present some of the experiences that we've had here so far. I field a lot of calls from other states, cities in our country, trying to, maybe we are, 4 or 6 weeks ahead of everybody else, but we're really not that far ahead in the grand scheme of things. Next slide, please. One of the things that, contact tracing is not anything new. It's not even new in the United States. And I think that certainly the public health nurses, they all understand and have been doing this for years with other diseases. And I think even a lot of the patients, a lot of the people in our community have also experience with contact tracing too. But this is just part of a larger community response to COVID. And this is what we were discussing before, is that when you're looking at the other countries and the other countries that have been effective, all of them have used social distancing, testing, contact tracing, isolation, and quarantine. And if you can't do all of these things in an effective, efficient, and rapid manner, then you really have no chance against COVID. Next slide, please. So here, you're really, what we talk about in Massachusetts a lot is really the 4 elements. And the contact tracing absolutely is important. But I think sometimes people misunderstand that contact tracing alone isn't useful unless you have anybody to trace. And that's, if you don't have your testing structures or systems in place, if there aren't people who are able to get tested without waiting in line, those times, that in Germany, that's really impressive, to get your results back in 2 to 4 hours if you're a first responder, and in 6 to 8 hours if you're the general public. That's something that is right now is mostly a dream in most of the United States. And after you trace, if you don't really have anything for people to do, if they can't prevent infection to other people, then again, your testing and tracing is just an empty exercise. People need to be supported to isolate in home or in a facility. And that support, there are many people, I think in our experience, up to 20% of the people that we call need support to isolate at home, and really would welcome if there were isolation facilities that were set up in their towns. Next slide, please. So if we really say that all four of these elements, all four of these activities are important to combat COVID, we also have to target them, and we need to outreach into specific communities. And we know that COVID, by this time, I think everybody knows that COVID doesn't hit everybody equally. It's our poor communities, it's our communities of color that are disproportionately effective. So how are you going to get into these communities with all of these interventions? Next slide, please. One of the things that we have learned in Massachusetts and is that there are local, to reach into these communities, you have to use the organizations that have experience in those communities. And the obvious ones here are the local boards of health. And this, in different states, these may be called differently, but these public health departments, which are local, they have decades of experience working with communities, working with people, making sure that they are linked into services. And the other major group I think that is important to work with are the community health centers. So there's networks, national networks of federally qualified community health centers that really are their mandate to work in specific communities, to work with different languages, and have very personal relationships. And so when you're number one, when you're calling, and you're talking to somebody who has gotten a diagnosis of COVID, to be able, for a community health center to say that they are that we're in this community, this is a name that there's name recognition there. And that sort of name recognition, that sort of reputation is priceless. I will give you some round numbers. We could say maybe the local boards of health, there are maybe 300, at least 300 nurses that are doing contact tracing. CHC staff, close to also 300 staff now in Massachusetts that are doing contact tracing. And for the CTC, these are now PIH employees that have been newly hired. There's about 1,500 of them. So we're talking over 2,000 people now in Massachusetts, all using the same system and doing contact tracing for COVID. And it's not just about being culturally competent. It's about providing high quality services. And it's clear at this time, even though we've been doing this for just a few weeks, that simply advising people that they need to isolate, advising people that they need to quarantine, the classic public health education, this is inadequate. People cannot isolate when they're living 6 people in a single house. If there are people who are elderly in their house and who are really vulnerable to COVID. And if you can't provide any sort of support, whether that's food delivery, whether that's a referral to a facility, whether that's childcare, whether that's delivery of medications, then the likelihood that you're going to prevent transmission within the home and even in the workplace, if this person is an essential worker, is really close to zero. So and I think that one, the local boards of health and the CHCs, they do have that experience. They do have that understanding about how to link people to local support. But overall, the project as a whole has to have that vision. The contact tracing project is not just a epidemiological exercise. If you want to, it's not a data collection exercise. If you want to have an epidemiological impact, then you have to think about the downstream activities after the call. How are you going to support people to do isolation and quarantine? And my last slide here, I think once you have very experienced contact tracing systems, then you're able to do even more creative sorts of contact tracing and integration with testing. Can you go to the next slide, please? One of the things that just came out yesterday or a couple days ago was a new recommendation by the Department of Public Health that all contacts in Massachusetts should be tested. So now instead of just going, what I'm saying here is that this is not just symptomatic contacts, this is asymptomatic contacts too. And we know that COVID, even before the onset of symptoms, can be very, very infectious. And this is the Department of Public Health's attempt to get ahead of it. So you can see there that normally we think of contact tracing coming after the testing. So a patient who is tested positive is now referred to contact tracing, and then there's an effort to look at the contacts. But now with the new recommendations, with a new fast track among testing sites, then those contacts can get rapidly tested as well, which can lead to new cases, which can lead to the discovery of new chains of transmission that need to be broken. I'm going to stop here, Reed. Thank you very much.
Well, thank you all very much to the three of you. And let's start to get right down to some of the key questions. And Anand, I wondered whether you could start out. You mentioned a little bit about variability, I think, in the criteria for determining whether a contact is significant or not clinically and requires, secondary intervention. Could you just elaborate a little bit more on what you have seen around the country, and then maybe KJ, you might be able to again drill down again on what you're seeing in terms of consistency or lack thereof on determining who is a significant contact.
Sure, Reed. I think clinically, what I've been seeing, of course, sort of 6 feet, and we know where that number comes from in terms of the droplet being a key mode of transmission. 6 feet without a mask. I think in terms of exposure, the length of exposure, I've seen 10 to 15 minutes is sort of what people are commonly referring to. And then we know that individuals may be most infectious in the couple days prior to being symptomatic. So in terms of contact tracing, I think people are really focused on asking questions of confirmed cases. When did your symptoms first start, and take us back 48 hours prior to that, who did you come in contact with? Now, if people are asymptomatic and test positive, of course, then it's sort of 2 days prior to the test. But Reed, I think this is more, information sort of that we've collected. Now, in our study, we looked sort of outside in other countries, and we couldn't find a lot of specificity there. And so what I'm articulating here is just sort of clinically what I hear folks really focusing on, but others may want to elaborate.
That's helpful. And KJ, as you respond, I'm also curious whether you have any benefit, not only of your beyond your own experience there in Mass in terms of the criteria you're using, but as you have been mentioning, you're talking with many other states. But finally, do you ever think that we have any evidence basis upon which to make a decision, or is this basically going to be pretty much, back of the envelope kind of calculation?
I think the evidence comes mostly from the countries that have been doing contact tracing for longer than the United States. And one of the things about Massachusetts and a lot of the here in the US is that since there is social distancing, since people are not going to work, most of the contacts are at home. So then the question is, once now we're going to work, are we going to have a huge increase in transmission? And what we learned from other countries that have been doing this longer is that yes, you absolutely do have a lot more contacts, but still those are close contacts. And these rules about 15 minutes, about within 6 feet, they do really seem to be borne out by the experience of contact tracing. And there have been a few studies of contact tracing, and what they find is that is still the close contacts that are where the attack rate is high. Casual contacts are very low, but you can have close contacts certainly at work. It's not just at home when people are going out of the home. But those close contacts have a very, very high attack rate, whether they're at home or at work.
Thank you. So I think we will be then, as you say, following the evidentiary basis of those countries that have been ahead of us. Speaking of which, Rudolf, let me ask you, you took some, and we appreciate the fact you took effort to indicate the political structure of Germany with its multiple independent regions who can free to do things as they sort of see fit, similar to the state-based foci in the United States. Do you think that this variability in different regional jurisdictions managing this issue on their own and not being coordinated necessarily, is that going to be a dangerous rate limiting step for success?
It depends, in my opinion. So basically, if we have a coordination on top, so there is a coordination group of all the different federal states that decides on the major milestones to be hit, like we close all the schools and we are closing the borders. But there has to be kind of a little variability for the states because they are differently hit. So there are federal states which are more rural and federal states that are kind of just cities like Berlin. It's a federal state, but actually it's a city, and there you need different measures to take, and therefore you need this flexibility. Also, I have to admit that the people who live at the border, for them it's sometimes difficult to understand why the shop is open on the other side of the border but not on their side. But still, it's better. You can react also faster on if you have this flexibility on state level.
Well, it certainly is a little bit. It is a little bit scary when you are, as you say, on the border. Given that people move from place to place, people will be traveling across borders, across intra-national boundaries, intranational states. And then, of course, people will be at some point before long catching airplanes to other countries. So it seems like we're sort of bedeviled, Rudolf, by the extraordinary interdependence and interflow of human populations in the modern world.
Yes, definitely. So in the beginning, also the state, the border between Hamburg and Lower Saxony was closed for non-business trips. So you couldn't go for walking around from one state to another just for holidays or for recreation. This has been relaxed during the last time, and now we are currently discussing about opening the borders to other countries. countries, which will probably be thing which happens during the next week.
Great.
And
oh, sorry.
Yeah, and then we will see how this will evolve. And they are looking to open the borders to other countries if they have kind of similar measures in place and if they have a similar number of new infections.
Great. Thank you so much, Rudolf. Anand and KJ, let me just ask you again to review, if you will, what you've learned from who is doing the contact tracing, and whether or not we have any lessons that we can learn as to whether these are should be professionals that were already doing this, people that are volunteers from community organizations who have been trained. What are the various permutations, and if you can, if we lessons learned of the models of those permutations?
Well, I can say that professionals. There are obviously professionals that have been doing this for a long time. So there are people in every state at the local level, the bureaus of public health, the departments of public health. These are the experts, and this really needs to be your core. Now, when you're having a pandemic and you need to bolster that core, then where do you turn? And I don't think it has to be people of that high level. I don't think they need to be nurses. I don't think they need to be doctors. They don't need to be public health experts. And I think there is a great opportunity for lay people who are highly motivated to learn how to do this. But I do think it's a commitment. I think it's difficult to do it as a volunteer. I think it's difficult to do it. And I also think that these contact tracing programs are going to be needed for, not just for 3 months, not just for 6 months, but for a year or more, maybe 2, even for 3 years until a vaccine is developed. So I think it behooves everybody to invest to really, I don't think you need to have a public health degree to be a good contact tracer, but you do have to be committed to it for the long haul. And there is, in our work in other countries, we don't ask community health workers in Sierra Leone to do contact tracing for Ebola for free. We pay them. And I think that's the same attitude that we need to take here in the United States.
Thank you.
I agree. I'll just add to sort of what KJ said. I think the key word here, Reed, is team. And looking across every country, and even here in the US, I think when you think about contact tracers, they got to be part of a team. So it's the individual doing the contact tracing, it's the trainer, it's the epidemiologist analyzing the data, it's the individual who's then, as KJ mentioned, connecting the close contacts with the services they may need. So it really takes a team. I think reliability is really important. A sense of service is critical as well. I think that's why a lot of countries first go to government employees, military. In this country, a lot of states going to the National Guard. I think the volunteer piece is great as well. There are some issues there I think we need to think about in terms of long-term, as KJ mentioned. But again, I think it's really about a team, a reliable team, and a sense of service and dedication, which is critical.
Let me just ask KJ to follow up on something there, and then I'll turn to you, Rudolf. I think we're trying to get in. And that is, do we have, is it, how necessary is it that we connect the contact tracer to the need for social support services? Given if the contact tracer suggests that the individual needs to be isolated, is it the responsibility of the contact tracer to then put them in touch with those social service enablers, or does their work stop at the end of advising the client?
In Massachusetts, we believe in the former, that just to give somebody a number to call, we know that is not going to be a successful technique for no matter what sort of activity or service you're running. And there needs to be a much more, if you really want somebody to get the support that they need, they need somebody to run that gauntlet, to figure out the best phone numbers to call, maybe to have called those agencies beforehand, just to know that, to prepare them for the types of, that there are COVID patients out there coming from the contact tracing teams, and they're going to have certain special needs too. You know, it's both effective, but it's also about speed. So COVID is fast. You know, if you can't isolate somebody within a day, then it really doesn't matter at that point. And we know absolutely that, you know, when a diagnosis of COVID comes, that's a mini crisis for that person and for that household and whoever they're living with. So we have to, you know, contact tracers for all sorts of reasons have to work very, very fast, and the social aspects of it are no different.
Thank you. Rudolf, and as you get in on this part of the conversation, we're curious about also whether Germany generally provides housing for people who cannot self-isolate, and do you have that kind of intensive social support service for them?
Yes, I just want to wrap up also on the other questions. So first of all, also Germany takes government employees, but they plan for 9 to 16 months where they need these contact tracers. And the government employees, they have to go back to their usual work, and therefore they are recruiting now new persons. And the difficulty with non-medical employees is the documentation, because they are called, these people, and afterwards the people, if they do not comply with what they are telling, they have to go to jail, or they have to pay fines or whatever. So they are prosecuted, and therefore you need a good documentation. And this is better if this and medical staff is more used to document. That's the first thing. And the second thing, I wanted to come back on the speed and the contacts, well, of the public health authority people who are contacting, or the contact tracers. So we have made the experience that that they call the people in quarantine each day or every day because they want to prevent depression, and therefore they have different teams set up which have different tasks, just to call them and inform them about the test, to ask them whether they need whether they need something else, or if they need to talk, or if they need food. And also a team that is just dedicated to give or to provide accommodation. So if the person cannot stay at home, the person is sent to a hospital, to a Corona hotel, which are actually hotels where they have to stay there for another 2 weeks in quarantine, and they get food brought to their door, and then they can take their food and eat that food. And if they do not comply with the quarantine, they can also go in they can also come into a Corona prison. Probably that is a nicer name, but where they are supervised and where they cannot go out. So where the freedom of movement is heavily reduced. So there are options, or there are options for accommodation.
Great. So let me 2 quick questions for you all. I'm going to squeeze a few in real fast. Number one is there going to be any role to play in either the antibody tests that we are seeing now being marketed? Will that play a role? And have we found that in the United States, the relative lack of testing, has that affected the capacity of being able to do contact tracing?
This is Anand. I'll just start really briefly. I think, and Reed, perhaps the second question was more on the molecular test to confirm or diagnose COVID, and the first one on the antibody. I think on the antibody, I think there will eventually be a role. You know, I think we need to let the science play out and get tests that are accurate, and then many questions there from, does the level of antibodies matter? How long might you be immune for? Can you get reinfected? So I think we need to let the science play out there, but I think there's a role. I think in terms of the second question, in terms of tests for the virus, I think absolutely. I think we've been behind the curve here in terms of testing, and I think over the last couple of weeks the country is ramping up testing capacity, and as that gets ramped up, there's going to be more contact tracing that's necessary. And I think as KJ can tell us, and Rudolf, this is really hard work. This contact tracing is labor intensive. The person hours it takes to do each trace, is substantial. So I think the needs for this will continue to increase as there's more testing in cases.
Thank you. And KJ, let me ask you to close us out with a specific example. So let's just say, KJ, that you're a teacher in the Boston school district starts to show symptoms of this disease. And now you are aware of that. What happens? Take us through the process in the next 3 minutes.
That person should be able to get a test, and I absolutely agree with you. It's a major bottleneck right now. That person should be tested to find out if they are infectious, and I'll come back to that testing part. But once that test is back, then this person will get a call and talking about when did you start to have symptoms. Then from that date, let's go 2 days before, because we know that you can be infectious even before the onset of symptoms. And let's go talk about everybody that you've been into contact to. So as we talked about, close contacts, 15 minutes, within 6 feet. Who were they? Go through your phone, just pull out your phone while you're talking to me, look at your calendar, maybe that will jog your memory. And then we can make a list of all of those people. And then when you hang up there, you start calling those contacts. And then you say, you know what? You were in contact with somebody. I don't even have to tell you who it is, but you need to go get tested right now. And you need to put yourself in quarantine because you do have a high risk of developing symptoms of COVID and becoming infected and becoming infectious, and you need to do this to protect your family. And so all of that has to happen very rapidly. And so the bottleneck of the testing isn't just having enough big laboratories to do a lot of tests. It's, are you testing the right people? Does that teacher even have access to testing? Do certain communities not have access to testing? Do certain communities of color, do certain poor communities, are they getting tested in the same way? Do they have access? Are there places where they can go to get seen? And then are those people going to get their test back in, like Germany, in 8 hours, or like in the United States, as in 5 days? Because I can tell you, after 5 days, you're not infectious anymore, the vast majority of people. So if this really can't be done at a very if that cascade of contact tracing, of testing, contact tracing, and isolation and quarantine can't be done at a much faster rate, then we're going to be continuing to struggle with COVID for the foreseeable future.
KJ, that's a terrific answer. I want to thank our panelists very much. This has been a truly informative conversation, and I think we've answered every question from a very intelligent and engaged audience. And so I thank you very much for that. And exactly on the hour, I turn it back to our hosts.
Thank you, Reed. Yes, that will conclude the webinar. Thank you, everyone.